Hello, everyone, and welcome to this edition of the Oncology Center of Excellence Conversations on Cancer Public Panel Discussion Series. I'm Ria Blakey. I'm the Associate Director for External Outreach and Engagement, and it's my pleasure to be one of the moderators today for the Strength in Numbers, Increasing Cancer Awareness While Decreasing Disparities session. This is in honor of April being National Minority Health Month, among other things. But before we get too deep in those thoughts, I would love to have our OCE Center Director, Richard Pazder, say a few words, and then also have our co-moderator, Bindu Kanapuro, introduce herself. Rick?
I'll be relatively short. Thanks for the introduction. This is a special panel that we have here, and we have a very diverse group of individuals to talk about the subjects. I'm really looking forward to this conversation. Again, Ria mentioned that this is National Minority Healthcare Month, and we really want to have an in-depth discussion on minorities, the challenges that they face in cancer, accessing cancer care, cancer prevention, etc. So we really are looking forward to really a lively discussion. We'll all go by first names here, and let's have some fun and education and come out of this as an hour and a half very well spent. And I think it will be a very well spent hour and a half. So I'll turn it over to Bindu.
Thank you, Rick. I'm Bindu. I'm a hematologist, oncologist, physician, and the Associate Director of Therapeutic Review. Our division reviews products for multiple myeloma and lymphoma. Again, welcome to this Conversations on Cancer. We're very excited to have this diverse group of panelists. And, you're all represent cancer advocacy groups, and you work year-round encouraging cancer screenings, education, and facilitate clinical trial participation and providing patient navigation support. So really, we're dedicating this installment of Conversations on Cancer to you all. So welcome again. Thanks for joining.
Yeah, it's the first ever COCA, we call them in-house, Conversation on Cancer. It's actually led by advocates. So without further ado, we're going to ask each of our advocates to introduce themselves briefly. This is an area where they're really just going to give you name, rank, serial number, and then we'll move into the meat of the conversation. So let's start with Jessica. Hi.
Hi, thank you so much. My name is Jessica Brescher. My pronouns are she, her, hers. I am a founder of SGM Alliance, which is a nonprofit group that works to increase the inclusion of sexual and gender diverse patients in clinical trials.
Thank you, Jessica. Hi, Melissa.
Hello, everyone. I'm so honored to be here today. My name is Melissa. I'm an enrolled member of the Meskwaki Nation in Iowa. I currently serve as the Chief Executive Officer of the American Indian Cancer Foundation, a national nonprofit that was established to address the tremendous cancer inequities faced by Native communities. Our mission is to eliminate the cancer burdens of Native people through improved access to prevention, early detection, treatment, and survivor support.
Thank you, Melissa. Good to have you. Hi, Audrey.
Hi, everyone. I'm Audrey. My pronouns are she, her, hers. I am Senior Director of Health Equity at the Cancer Support Community, also known as CSE. We are the largest professionally led global nonprofit offering 100% no-cost free psychosocial support to both cancer patients and their loved ones. I am so happy to be here today to have this conversation with you all.
People love the sound of free, Audrey. Thank you. Winora, how are you today? Hello.
Hello, good afternoon. My name is Winora Johnson. I'm a 3-time cancer survivor, and genetic testing identified me as being Lynch syndrome positive. I'm a very passionate patient advocate and currently serve as the board president for Facing Our Risk of Cancer Empowered, or better known as FORCE. And since 2014, I've been actively involved with various organizations who promote changing policies, guidelines, educating patients about genetic testing, clinical trials, and cancer survivorship.
Oh, we've got a good group here today, including Barbara. Hi, Barbara.
Hi, everyone. My name is Barbara Segarra Vasquez. I live in Puerto Rico, a 2-time breast cancer survivor. We don't have like a network of Latinos, so part of what I've been doing with Dr. Ramirez is working in advancing the science of cancer in Latino, a conference that is given every 2 years. And this last February, we did for the first time in the United States, a training for only Latino advocates. And I can talk later about why this is important to increase clinical trials. Thank you
Yeah,
for
I was
having me.
fortunate to be there. Thank you, Barbara. It's good to have you today. And hello, Allison.
Hello, good afternoon. My name is Allison Silverman. I am the CEO of Stupid Cancer. We are a national nonprofit whose mission is to help empower everyone affected by adolescent and young adult cancer by ending isolation and building community.
I have to tell you, Allison, the name of your organization is my favorite on this panel. I might just call on you several times just to hear you say it, just teasing. But one of the things that we do have to say right at the beginning is there are many things we could talk about during the next hour or so. One of the things we want to make sure to talk about is outreach and engagement of each of these advocacy groups, thus the idea of this being an advocacy-led conversation on cancer. And I have to tell you, the background on this particular program goes back to, I think it was last fall, when Audrey and the cancer support community came up with a film version series, if you will, regarding clinical trials. And we're going to play that here in about 13 seconds. And the reason I'm giving this sort of lead in is because I want to make sure we have all of the IT organized for it. And then after we play it, it's just a clip, just 3 minutes. After we play this clip that really inspired today's conversation, then we'll begin the rest of our conversation and talk about all the other aspects. So I hope that was sufficient, IT folks. Let's play that clip.
The institution carries a lot of that burden of mistrust through history. Patient-doctor or patient-provider relationship, do they distrust that individual? Not so much. They more distrust the institution that that individual represents.
So the causes of medical mistrust are multifactorial. There are things that have happened historically, centuries ago, decades ago, yesterday, that really can impact how individuals and communities feel about the medical system.
My mother also was a double cancer. A survivor eventually passed from lung cancer. She had a very negative experience with a surgeon. And my brothers and I had real challenges with this surgeon.
A lot of people think medical mistrust is about history. History is important, but it doesn't discount what people experience today. Because never in any time, including today, have people of diverse ethnicities and races receive the same care as the majority. And that is happening today.
We do need to talk about the fact that racism still exists, but we also need to make sure that we are thinking about the healthcare system as a way that really can help to be a balm, to be humble enough to say, who is this person who's sitting in front of me? One of the strategies that I used when I was the associate director of the Cancer Center in North Carolina was really thinking about populations that may be impacted by barriers. So when I was there, I established a population health navigation program. One of the first things I did was say, go out in the community, spend time. Make sure that you are known. Again, it's that trust building, it's that engagement piece. And we really implemented a program where if a person was coming in to the Cancer Center for the first time, we did a screening 2 weeks in advance. We would give them a call. And we even mentioned that there's going to be a team of individuals talking about the complexity of cancer care. And in fact, they may be offered clinical research as part of their care. For each of those navigated populations, we improved clinical trial enrollment by 50%, 50.
50% was the last moment there. How about, Audrey, you give us a sense as to why this clip from the video series, and there was a whole film festival, was there not? Tell us more about how this came to be, and want all of the panelists to feel welcome to respond after Audrey gets us started. Audrey?
Sure thing. So, we know that racial and ethnic diversity in cancer clinical trials remains an ongoing concern. We've seen this in the research, right? Recent studies have confirmed that participation to prevalence ratios continue to be low for not only Black and African American patients, but also Hispanic and Latinos, and that for certain cancer types with a high prevalence in certain communities, such as, let's say, multiple myeloma, for example, there are 22% Black Americans comprise 22% of those patients, but only about 4.5% of actual clinical trial participants. So when we take some of these statistics and that data in mind, we thought, well, what can we do about this as an organization, right? We want to improve clinical trial diversity. We want to not only improve the diversity in clinical trials, but also have that data so that we know which treatments are working for which people. And we thought, well, what about a docuseries? What about if we could feature not only folks from community of color who are from the medical field, but also past clinical trial participants who are also from communities of color, who are able to say, this might not be your experience in clinical trial, but this was my experience. And if you have questions about it, if you're interested in learning more, not only watch this film or watch this series, which, yes, thank you for mentioning, we have had several accolades and awards. We were featured at an international film festival. Stupid Cancer was also an award recipient at that same film festival as well for their work in this space. But we, through increased exposure, not only with patients and their loved ones, but also HCPs and healthcare professionals, been able to really get this conversation going about what it's going to take to move the needle forward for clinical trial diversity. I do also want to note that CSC has other programs like this. We have our peer clinical trial support team, which does have, again, past clinical trial participants in this particular iteration from the Black and African American community, who are then matched with Black and African American cancer patients who want to learn more about clinical trials, who want to make an informed and empowered decision. We train these peers in the peer model and then have had these conversations. This was an IRB exempt pilot study that was done, significant improvement not only in clinical trial perception, but also in willingness to talk with the healthcare provider on behalf of the cancer patient about clinical trials. Our next iteration is going to be with Spanish speakers, both bilingual and monolingual, but I will not steal the thunder of some of my other co-conversationalists, we'll call it, since it's not a panel, it's a conversation. I will leave it to them to talk more about what's being done in other respective communities. But I just wanted to underscore the film series. The whole point is to start a conversation and really be able to feature folks who have that lived experience, not only as a cancer patient, but as someone from a medically underserved or historically under-resourced community, to be able to share not only what they've been through, but again, from the medical perspective as well, with these Black and other practitioners, see not only their professional with their professional hat on, rather, but with their personal hat on, and having their experience as both a Black doctor or a doctor from the community of color and someone who's interested in moving things forward.
Thank you, Audrey. Bindu?
Yeah, no, I think this has been, some of the messages I heard from the movie, even though it was a short clip, are very, very, very powerful, right? Because one of the, the doctors asking, like, who is this patient who's sitting in front of me? Like, really understanding, the patient in front of us. And Audrey, just as a follow-up, you mentioned this was a docu-series, and, what are the other, aspects do you have, in this series? And maybe I want to hear from the others. I think I did read about the peer support, and again, that's really powerful because the lived-in experience is really important. I read one of the blogs, and the patient really mentioned how, her physician really did not talk about the clinical trial because they had already assumed that they have some financial burden and she won't be able to participate. And she had to search, the internet, and the peer support was really important. And I know, Venora, you've done a lot of work on that as well. So what have the other advocacy groups really done in terms of community outreach and engagement and enrolling patients on clinical trials? And what have you heard from your groups on this topic?
Bindu, if I could just, quickly jump in there, because I think for me it's twofold, and I'm going to show you why quickly here. This is a copy of my genetic test. It's a couple of years old, but that genetic test saved my life. And so it's genetic testing coupled with clinical trials as well too. And what I love about what FORCE, or Facing Our Risk of Cancer Empowered, is doing is they're doing a peer navigation program where it's matching a one-on-one support for patients who, number one, have a high risk of cancers that are hereditary. And when they first get this diagnosed that they even have a hereditary cancer, someone they can talk to. I myself was one of those navigators and remember talking to Lynch syndrome patients who just didn't know where to go or turn. And this is long before you even think about clinical trials. This is just to get them thinking about their diagnosis of what they have and where they are. And part of this program also sends out resources for them to review and really think about it, so that once the patient understands what exactly is going on in their lives, then maybe they can better navigate it themselves after they've gotten that peer one-on-one support help.
Yeah, I think you bring up really a good point, because genetic testing, I think that's really really important, because a lot of the trials these days we are seeing are testing, based, we understand a lot about precision oncology. And I think it's really important that there is awareness and education about who should be tested. And so could you also just talk a little bit more about what are the other outreach that you've done to increase this testing, the need for genetic testing, as well as, clinical trial participation?
Oh, absolutely. I mean, for FORCE, it's just, having a website full of information where people can get information that is reliable. It's a vetted source of information and not just something just Googled. It comes from scientists and researchers who themselves have provided adequate answers to help a person navigate their life, so that, they know what direction to turn. So we have a program called X-Ray, where individuals can look up any specific research regarding their mutation. I myself, I have an MSH2 mutation. If it's something I want to look up, I can look up within the realms of X-ray. And then from there, believe it or not, that's how I found I was able to participate in a clinical trial. So it's a lead.
Can I actually interject with just a very brief follow-up question? When we were talking about precision medicine and different options for testing, I know that for our patients and their loved ones, often questions of access come up, right? Can I afford this testing? Does my insurance cover it? Can you just very briefly share, for anyone who might be interested, how accessible genetic testing is and how FORCE makes it more accessible for those who might not otherwise have the opportunity?
Oops, I can, again, referring back to our FORCE website, where we actually can provide patients or those who are looking to have either the cost itself smaller or maybe removed altogether, so that patients don't have to think that this is a full burden cost that they have to take on themselves, and thus not even bother. Because if I'm uninsured or underinsured, the last thing I'm going to think about is, another test that's going to possibly cost me out of pocket maybe hundreds or thousands of dollars. And this is where FORCE has been very helpful with providing information and other organizations who do provide assistance in that manner. So thank you, Audrey, for bringing that up.
Yeah, and on the topic of access, I think it's really important. So, Melissa, I wanted to ask you, tell us about some of the successful programs that the American Indian Cancer Foundation has undertaken. I think there's a lot of some of the populations, like the American Indian cancer populations, there's a lot of trouble with access to care. In fact, we know that sometimes people have to travel hundreds of miles to actually even get cancer care, leave alone participating in clinical trials. So could you talk a little bit more about some of your advocacy group activities and having this awareness, as well as how do you facilitate cancer trial participation for your groups?
Yeah, great question. And I'm like, how do you bring in kind of the previous conversation into the current one? Because I think it's all relative as we think about some of those disparities and inequities faced by Native people. As a national nonprofit, looking at some of the programs we have, one that was recently launched, ACAP worked with the University of Minnesota, NCI, and Indian Health Service to culturally tailor texting called Smoke Free Native. So we know there's Smoke Free Native that NCI has created. And so how can we culturally tailor that and use that as a opportunity for Native communities to feel empowered to quit, but in a way that is culturally tailored to them and for them? And so this project worked with community members and brought in, cultural experts and used the Gathering of Native Americans curriculum or approach, which, looking at a strengths-based approach that seeks to prevent and reduce substance use through teachings of, 4 Indigenous worldview themes. And so they looked at belonging, which is that cultural identity and connectivity and mastery, which is, again, that empowerment I talked about, that interdependence, resiliency and being able to follow through with it. And then generosity, oftentimes understanding, we want to quit commercial tobacco, because for other people, not just ourselves, and, how do we help our other community members see that we can do this? So this texting program, again, how can we take each message and tailor it? So, looking at some of the words that could be tailored. One example is, smoke-free text will tell you to take 10 deep breaths when you feel stressed or emotional this week. And so for Smoke-Free Native, looking at understanding your breath is sacred, take 10 deep breaths when you feel stressed or emotional. So just that one beginning word of understanding your breath is sacred and bringing it back to that. So again, that is one of our many ways of commercial tobacco cessation efforts that we do. And it's, again, national. The other one I wanted to highlight is, our awareness campaigns. Awareness campaigns can be an opportunity, especially for us, organizations that are national, and how we can use that digital platform to really reach as many community members. And, I love our, campaigns, especially Indigenous Pink, which is for breast cancer, how we can, provide opportunities for communities to hold events that are tailored for their community, using toolkits, looking at social media posts, what events can they do to raise awareness on the importance of breast cancer screening, early detection, and even, clinical trials. How can we bring that information to these communities that oftentimes aren't even included in the conversation or included in the data? And so, knowing that our communities have the knowledge and wisdom. So, at ACAP, we really lean in on what the community knows and how and where their readiness is to implement some of these opportunities. So I'll pause right there.
Yeah, that's good. I think, with those, I think education and awareness is really important, but maybe you all can comment on some of the barriers, that you have heard from your communities for participating in clinical trials. And maybe Barbara, you can start. Could you comment a little bit about some of the barriers for Latinos and Hispanics to participate in clinical trials, and how can we better educate people about clinical trials? I think, Audrey, you had a nice, part of your docuseries where, you highlighted the fact about the mistrust. I think that's really important. But, we've heard that there are multiple barriers. And one, as I just pointed out, is, there's, even if you're aware, you may not be able to get to the site where the clinical trial is being conducted. And then you probably have to have, the financial, you should be ready with that to, ensure that you're able to participate in the clinical trial. So maybe you all can highlight some of the barriers that you've noted and how and what your groups are doing to, maybe reduce some of these barriers to clinical trial participation.
So if I can, I will start with some facts important to know about Latino Hispanic, right? We are the fastest growing minority. We actually represent 20% of the population right now. It's the first cause of death, not the second one. It used to be heart disease, and now it's the first cause of death for women and men. And language is a huge barrier. 70% of the Latinos that live in the United States don't speak English at home, and 25% don't even understand English. So you can imagine most of us who had gone through cancer trying to manage what cancer is in the language that you speak. When I was diagnosed in Puerto Rico with my St. Cord children hugging each other, saying, you're gonna be okay, it's all okay, drinking all the natural things that everybody. So you imagine being in the middle of the United States, not understanding, and when your physician is talking to you, you're lucky if you have a translator. So you're looking to the translator. You don't know that feeling and commitment that your doctor relates, right? So let's begin. That's the starting point, right? So let alone trying to participate in clinical trials. Again, language comes into like the main barrier. It's about education as well, right? It's about that. Another fact about the Latinos living in the United States, 20% are uninsured, right? 20 more, a lot of them don't have steady jobs. So they have more than one job that doesn't pay sick days. They don't have insurance. So they're trying to struggle just to get their treatment, let alone participate in clinical trials. Sometimes there's a myth that they don't want to participate, and there was a study done by Unger, and it's not that they don't want to participate. One is far away from where they live. Second, sometimes the inclusion criteria eliminates Latinos as a fact because they have a higher percent of hypertension, they have a 14% of diabetes. So if those are the facts to be included in a clinical trial, just by the inclusion and exclusion criteria, they're not even considered. Then you add that nobody speaks Spanish or the protocol is not done in Spanish. And then they give somebody to talk to you that you don't even relate. So I think, part of it is first education, and not only for Latinos, the general population should understand what a clinical trial is. Not when you're sick, not when you're diagnosed, and people think, oh, now they're offering this because I'm gonna die and this is the last research. So we have to demystify that as communities, right? Talk to people, every opportunity, our grandmother, our children, our children's friend, take that away. Second, we have to have, people who do trials have to know their community. And if you are serving a large Latino community, if you as a PI are not a Latino, hire staff, hire a nurse, hire a navigator that will speak the language. I met a lady the other day and she was frustrated because she's now metastatic. She used to have a physician who spoke Spanish. She left and now she's stuck with another doctor that is trying to learn Spanish with her, and he makes it fun just to ask, oh, how do you say hi? How do you say goodbye? All those elements. And the last thing I will do, and I'll shut up, I told you, Ria, I can talk. The last thing is that I have noticed is the lack of Latinas as advocates. And there's not a community, and I'm here not representing an organization in a community because there's none, right? We have in breast, Black women have been very active, and we have great community advocacy group. There's none for Latinas, none. So part of what we did in the last Latino community training, Advancing the Science, was we got funding, and we were able to bring 15 advocates, Latina. They had to be Latina descent, and they all spoke Spanish. And our first Zoom, they said, oh, it's the first time that I see people that look like me. And from that, just meeting each other, they learn about the opportunity. 2 already got scholarship for ASCO, and this was last February. 1 wrote yesterday and said, oh, I'm gonna do DOD, and I learned it because of what you said. So it's lack of information. And if I win the lotto or get to retire from the university, that's my next step, to form this network of Latinas. So I'll shut up now.
Barbara,
No.
can I just add just really quickly, Barbara, always keep talking because it's important, the work that you do and what you say. And at some point, I really do want Jessica and Allison to weigh in as well, because I'm sure they have important programs. But Winora, go ahead.
No. I was just going to say, also along with that, Barbara, that was just really heartwarming, heartfelt of what we're experiencing, probably on all levels. And what I appreciate about change that's taking place now, I know you mentioned about getting more patient advocates. And when you do get to that point where there are more Latina patient advocates, there's a lot of work for us. And what I appreciated, what the DoD has done, they are now incorporating patient advocates in reviewing grants. And this is also passing along to other organizations who are giving out research grants and funding, that they are incorporating and using the patient's voice or patient advocates to further their research, to help them understand what they're not getting from the patient's point of view.
Allison and Jessica?
Yeah, I mean, I think from the AYA perspective or the adolescent young adult perspective, I could say yes and to all of the things that my other co-conversationalists have been talking about. We did a study over the past 3 years called our Health Disparities Town Hall, where we just kind of took a step back and said, what's happening out there? What is happening within the AYA community, those who identify as patients of color, LGBTQ+ or disabled, to really understand where the gaps are happening and when conversations in clinical trials are happening and when they're not. And, I think one of the things that we saw that has been said by the other folks on this call is, no one's talking to them about them, primarily because of assumptions, right? You're too young, you wouldn't understand it. You're too young, you don't have enough money to deal with it. You don't have access, you won't have the capacity. And there's a lot of intersectionality. I'm sure if we all kept talking for hours and hours, we could say, yep, I saw that and we saw this, and we've got people who, sort of cross all the lines when it comes to accessing clinical trials and treatment and care. And, we're talking about within the AYA community, we're about 4% of the cancer diagnosis each year. It's 15 to 39-year-olds. So you could even argue that that's a small sliver of the entirety of the cancer population, but still seeing all of these themes pop up consistently across all of our different communities. And, I think one of the biggest challenges that we see specifically with AYAs is all of those other things that are happening in your life at that time, then again, impact your ability to access a clinical trial, even if it's been presented as an option for you. So maybe you can't take time off work, or maybe you don't have childcare to travel to the center, or you're too focused on finishing school, all of the things that happen in your adolescent and young adulthood that can have really detrimental impacts on your treatment, because you're so many balls are in the air at the same time. So I think, for all of the points that the other folks on this Zoom have brought up, I think are true across the board. And, to sort of put an exclamation point on what Melissa was saying, it's really understanding that community that you're approaching and understanding the differences in what their experience is. And, down to the individual level for sure. But when we're talking about American Indians, how do you approach this community with the information that they need in a way that they're going to understand? How do you do that for patients of color? How do you do that for AYAs? It's not a one and done kind of thing. And so I think we really need to understand all of the different facets of accessing clinical trials, advertising clinical trials, and all the pieces in between.
Yeah, thanks. I just wanted to make a comment. I know, there's several of, and I completely agree with you, Allison, that, as if we keep talking, I'm sure there'll be a lot of points that we can, bring up that are common. And, one point I think, just about the eligibility criteria, I think there's a lot of efforts to broaden the eligibility criteria. And so, that's just one aspect of it. And again, Allison, to your point that the adolescent and young adult group, there's a lot of things going on in their life. And so it's also about fertility issues, like when you're at that age where you're also thinking about how does this impact, fertility or survivorship, you're starting to get, treatment at a very young age, and what does it do for your future? So there are a lot of things I think that, will impact how the adults and young adults and, view the cancer and cancer treatment. So Jessica, I know there's some, just to, piggyback on this topic, what are some of the barriers specifically, in terms of the, enrollment of patients who have sexual and gender minorities, and really, maybe you can talk about why is it important to, have the enrollment of these patients?
Thank you. So again, this could be a yes and conversation, and we could all be here for hours talking about this. The kind of to the first point, we actually don't know if LGBTQIA2+ patients, we don't know how represented they are in clinical trials because we don't collect that data. It is, you can go in and we can get a vague idea of, the demographics as far as race and ethnicity are concerned in clinical trials. It's not collected perfectly, but it is collected. And so we can have conversations like, well, 22% of multiple myeloma patients are Black, but only 10% in clinical trials are. We can't even start to have that conversation for sexual and gender diverse patients. So that's one of the first topics that we've been tackling within the pharmaceutical space. So we work more with industry and how from a top-down approach, how do we make clinical trials more accessible? And the inclusion-exclusion criteria is another one. We don't know how many people are there, but we suspect that we're not well represented. We know that in eligibility criteria, if your first criteria is male or female, 18 years and older, you are excluding transgender, gender nonconforming patients right there. When you have exclusion criteria like cannot be on HIV medication, you're excluding people that are on PrEP both prophylactically or they have it, they're undetectable, right? And so you're excluding a population, maybe not on purpose or without putting the thought scientifically into it. It's just kind of this blanket statement that ends up in a lot of clinical trial protocols. And we know that there's this medical distrust also carries into the LGBTQIA2+ community. It wasn't that long ago that homosexuality was illegal in parts of the United States. And here now we know that particularly around gender identity, we have doctors actually saying, oh, I don't care about this person's pronouns because I'm not going to feed into their mental disorder. So we know that about 25% of LGBTQIA2+ sexual and gender minorities. Sexual and gender minorities avoid going to the doctor for routine treatment. 30% put off necessary treatment because they've experienced violence at the doctor's office. And you talk about treating the whole patient. If they are afraid to even go to the doctor and put it off until they are already very sick, we know that with cancer, the sooner the better. If you wait until you are extremely ill, you are at a further point in your cancer, you have a higher grade, you have a worse prognosis. And if you can't get into a clinical trial because you happen to be on PrEP prophylactically, it leads to a bunch more, it all feeds into itself and these disparities. But again, I could go on for hours, especially in oncology. Clinical trials are frontline therapy in some cases. We know that 50 to 60% of oncologists also do clinical trials. We know that risk factors are different in the sexual and gender minority community. Bisexual women have the highest smoking rate in the United States. And so this all kind of feeds in. And the first thing we have to do is even just collect basic data and have awareness that, yes, your sexual orientation and gender identity do impact your health. And they impact your health outcomes. And that is something that needs to be addressed all the way up at the industry level, because that's where the change has to start.
So Jessica, maybe as a follow-up to that, so what has your organization, could you comment a little bit about what your organization has done in terms of, reducing these barriers?
Sure. So we're a baby organization. We've only been around for a year, but what we have done is create a collaborative space, a coalition of about 20 pharmaceutical companies, contract research organizations, technology solutions providers, and different specialists in each of these areas, and have started creating working groups where we allow people from different companies to come and share their expertise. What have they done that works? Johnson & Johnson has a Libertas trial, which is a gender-inclusive prostate cancer trial. So a prostate cancer trial that includes everyone, no matter what gender you are, to be enrolled. We know that certain companies are collecting sexual orientation, gender identity, and intersex status characteristics on their patients. And this is a first step to being able to understand patient profiles. So we are collecting people and collecting expertise to kind of share lessons learned and provide guidance to other companies to do that legwork for them to be able to implement some of these things across. We have data collection, we have inclusion, exclusion criteria, like I mentioned, PrEP a couple of times, but also, hormone replacement therapy. Everyone's transition, if they choose to transition, looks different. And also looking at stigma on the sponsor side and also on the site side. What can we educate? How can we have investigators be able to have these conversations with patients in a very safe and culturally competent way? We find that a lot of doctors want to have and want to include sexual and gender diverse patients, but don't know how to ask, don't know which questions to ask, don't know how to collect that data. And so that is another thing that our organization is providing.
If I may also offer an answer to the question and piggyback off of some of what was being said. I can hush otherwise if needed, but since it's a conversation, Jessica, I'm glad that you brought up the data, right? And having the importance of data collection. Cancer support community has done a lot of work in this space, especially on the qualitative research side, but also quant. So we have worked with various communities, Black and African American, Hispanic and Latino Spanish speakers, rural community members as well, right? Because when we're talking about minorities, we're not just talking about race and ethnicity, we're talking about where someone lives and how that impacts their access. We have asked folks, what are your psychosocial support needs barriers? What are the factors that fuel medical mistrust for you? Recognizing that no one group is a monolith, but if we have more information about these respective groups, then we can develop programs to better serve them. And so with that in mind, we have heard from patients that these health-related social needs, these social determinants of health, these barriers that we talked about earlier in this conversation need to be addressed in order to enhance the likelihood that someone will want to participate in a clinical trial. If I don't know who's going to take care of my kid, as Allison mentioned, then how am I even going to be worried about getting to the clinical trial site? If I'm not sure how I'm going to pay rent, why would I be talking to you about this treatment trial or the surveillance trial? I have other things on my mind. And so CSC has a helpline. Again, all of our services are 100% free 99, no cost to the patient or the loved one, right? And the helpline navigation team has specialized services. We have a CAR-T navigator. We have a clinical trials navigator. You can call, you can text if you prefer texting. You can even work with a navigator via email instead if that works for your schedule or you're super busy, and say, hey, I'm interested in learning more about clinical trials, or hey, I'm concerned about where my next meal is coming from. I want to be able to talk about other things related to my cancer care, but can you please share resources with me in my local area to help with this? We work alongside our 189 network partner locations to make sure that these needs and these concerns and these barriers really are being addressed. But then we also have educational resources in our Frankly Speaking About Cancer series, and they also focus on different populations and communities, our LGBTQ plus folks, folks again in rural communities, people from different racial and ethnic communities as well. And Barbara, I'm happy to note that many of our resources are available in Spanish. They're not just run through Google Translate, right? It's not a disrespectful translation. We have cultural adaptation and we take it with the approach of cultural humility. I'm really looking forward to seeing how much more we can do in this space. On a personal note, I'm a first-generation American. My dad passed away from colorectal cancer when I was in my early 20s. He emigrated from Haiti in his adolescence. And so I've seen firsthand how some of the language barriers that you mentioned really do play a role. I think cancer in and of itself is its own language, regardless of what your first or preferred language is. And so when we take all of these other considerations into play, it really does drive the work that CSC does and our approach with also partnering with other organizations that maybe have more subject matter expertise in certain areas than we do.
And it's conversations like this, and that's why we need more people to listen to it, right? I'm only one, and I can now go and tell to my community about your services and CGM and et cetera. But if we don't have people listening and conveying that, we have the same people even applying for scholarship, right? And I have been the privilege of working at SWOG and learning more about, sexual gender minorities. I work with another Allison that you must know her, Allison, at SWOG. And she had taught me a lot about the impact that young AYA patients have that I never thought. They don't have savings. They're just starting to work, the things about you said about taking care of your kids. And so when you are impacted in that life journey really matters, right? Because I had already 2 kids when I was diagnosed. So even about pregnancy wasn't in my worry because I had already 2 children, but these are other issues that AYA have and nobody talks to them and say, no, you just have to save your life. No, that is not the issue, right? So I think I consider myself privileged to be able to share podium with people like you and learn more and get to my community. But we need to, and I congratulate FDA for doing this, in the center, because this is what we need to learn from each other and have. I work as also Melissa, part of, maybe you didn't mention, and you can go into about how genetic testing impacts the Indian community in other aspects that we don't think about it, right? And maybe you can elaborate that. I learned in another committee that that's true because it's ancestry and things. So I don't know if you want to elaborate on that.
Yeah. I can.
No, go ahead, Melissa.
Thank you. Again, I think, Allison strengthened that statement for me again, understanding everyone has their experience, their trauma, right? Understanding like bad research that's been done in a lot of our tribal communities. So how can, we at ACAF gather information and find ways to build trust with providers, with, researchers doing clinical trials, to help understand the importance and the benefit that genetic testing could play, right? And that it is an option. So again, how can we give as much information to our community members? And again, what's the benefit? Or, even, again, what are some of the risks, but understanding too where culture plays a role and, does this community or these traditions allow for, someone to use their blood and take it for testing? And so that plays a huge role as well. So one of the projects we were just recently funded for here in Minnesota was to gather information to help raise awareness on the opportunities for clinical trials for American Indians here in Minnesota. And I think, oftentimes our community is diagnosed at later stages. So again, what's your opportunity to participate in trials? And then, understanding all the complexities in this conversation so far, but then you also have to add Indian Health Service, and it's not insurance, and helping people understand the role that Indian Health Service plays or doesn't play in treatment and clinical trials. So thank you.
We drill down on some of the differences in the communities. And I wanted to start out with Melissa, and you mentioned the Indian Health Service. And, one of the things that I think is unique about the Indian situation, the Native American, is the geographic isolation frequently that they may be part of, so to speak, and how healthcare is delivered there. You mentioned the Indian Healthcare Service, and generally that's geared toward more medical care. But I'm interested in how cancer care is delivered there, especially when you're potentially dealing with a remote geographic location where they may not have sophisticated medical services. And I was wondering if you could talk about that, because I think that's an important difference that many other groups may not face. If you could talk about that, I'd be very interested in hearing that.
Yeah, so we think again about looking at communities that, again, Indian Health Services for, like you said, primary healthcare, right? So how can they, again, work with other agencies, other entities to see prevention as part of healthcare, right? And not necessarily not primary. And so some of the communities I think of in some of the conversations we've had recently around, colorectal cancer was just, awareness campaign was in March. How can we look at these communities, say, in Alaska? And oftentimes you can only get to them by plane. And so understanding, like, to get to any appointment, you have to take a plane. And again, what is the need to want to get this screening or this test when you've, only heard bad things about said screenings or, experiences from others in the community? And so, again, what is IHS's role, and how can, we look at others, say, what are other tests outside of, colonoscopy? How can we get a test out there to, have those navigators work with the community, have somebody from the community play that role to try and get our relatives screened and then, kind of go from there. And even, here in the lower 48, same situation. A lot of our tribes are located in rural, remote areas and are a 20 to 30 minute drive in an ambulance. Like, it's not an opportunity to go up the street or up to the next suburb to get, basic health care. Yeah. So I don't know if that answered your question, but.
Yeah, and even as far as treatment goes, obviously for some of the very technically refined treatments, CAR T cells or bone marrow transplants, those obviously could not be delivered on a reservation. Okay, so there would be referrals and separating many times people from their support systems and families and many times people don't have the financial means to access these, as well as the family and social means also. It would mean them being separated from people that they love, et cetera, during the most critical parts of their life, which I think is something that we should consider also.
Yeah, and I think, at ACAF and other organizations, do we look at that larger level, understanding that, Indian Health Service is a trust responsibility of the government, but it's very underfunded. I think we are looking at some of the numbers. American Indians per capita, individual annual is about $6,000 compared to inmates in federal prison is around $9,000 a year. So again, where are we underfunded? And, how does IHS and how can we advocate on that level to get more funding? But then on the individual level, like you said, how can we have a navigator who has to refer this person out to a whole different system? And again, what's the role of electronic medical records, or what's the role of somebody in the community that has gone through that treatment away from their home?
I think this also speaks to the importance of bringing the services to the community, not always expecting and asking community members to go outside of their comfort zone, outside of their geographic area. And instead of just repeatedly having this conversation about what needs to be done, actually taking action. I'm really proud of the work the cancer support community has done with our American Indian and Alaska Native population. I can't name the corporation like the proper name because, proprietary information, but in Tuba City, Arizona, we have partnered with a large regional healthcare corporation there since 2020 and have served tens of thousands of cancer patients who live on tribal land in that area. We have worked not only with oncologists at that center, but also folks who practice more traditional medicine. Again, that cultural awareness, that cultural humility, that cultural competency. And we haven't asked folks to go hours away. We brought the services to them. I want to know that this took a long time, right? There's trust building that needed to happen, rightfully so, because we're not only talking again about historical context, but contemporary experiences, but we made it happen. I'm really proud of that. I'm proud of partners like Melissa and her input on some of our professional advisory boards and panels. We really need to, I think, move into a space as we talk about next steps and directions forward of just doing and seeing how we can course correct versus also noting the barriers without having these solutions in place.
Yeah, Audrey, you bring up and thank you for for your organization's work on that. I guess that brings up another question, and maybe Melissa and Audrey, both you can answer or others can comment. Like, what's the best way for like the non-tribal institutions or other institutions to partner with tribal nations and entities to like further reduce equity gaps? Like maybe Audrey, you have some comments on some best practices that you noticed, or any way that the non-tribal institutions can partner.
Yeah, so I'm going to just caution by saying my answer will be very brief. I don't think it would be fair of me to talk about building trust in tribal lands or with tribal folks and take up most of the answer time. So I will just say again, being willing to actively listen, being willing to approach these conversations with kind of the long game in mind. It's not going to be a 2-meeting thing and then we have a project charter and we can stand it right up. We need to build trust. We need to not only be engaging those practitioners in the area, but again, the patients, their loved ones, recognizing that there are family systems, there are community systems. And finally, per our research, they're already trusted members of the community. They may not have medical degrees. They may not have the credentials that we're used to talking about in academic circles, but they are very much trusted and respected in their communities, being willing to lean into those conversations. I'm going to be quiet though, because I think really this is a question for Melissa and talking about the community that she's a part of.
Thank you for that. I did, I was interested in hearing again as a non-native entity, like how you see that work. Because I think it's important again to be in that room and be in that conversation. And, both ways, like we can't bring every cancer treatment way to our tribal communities. Unfortunately, like I would love if Tuba City existed in all 574 tribal nations for that. But I know, even since they've opened, they've had their struggles, unfortunately. But for Navajo Nation to be able to do that has been amazing. And if that can serve as a model and what entities we need to bring in the room to make that happen, I think would benefit so many of our communities. Some of the work that I think about to that answer is, again, how can you build trust and how can you, some of the work we do is reclaim Indigenous health and healing with culture. And I don't know if it's Native communities, we like to turn words into verbs. But again, how can we re-indigenize things that have always been there? May just be not brought into the patient room, but our ways are there. We look at traditional tobacco as healing versus tobacco cessation. How do we use our language to come into the room with some of these resources and our toolkits? And again, how can we work with providers to understand, say, how come this 70-year-old man doesn't want to get a colonoscopy? He may be a boarding school survivor who was sexually abused. So I think bringing these type of conversations, which can get very emotional, to the room and being very authentic and real with it, unfortunately.
Melissa, one of the things that we found very interesting that resonated with me was when we did a Conversations on Cancer several years ago on the Native American community, particularly the Navajo Nation from New Mexico, I believe. And one of the things that was brought out that was kind of shocking to me was that in the Indigenous language, there was no word for cancer. Okay. And, if you don't have a word for it, it exposes and rips off kind of the wound here, so to speak. You don't have a concept of it, even a word, and in the proper Indigenous language. So it was really an interesting discovery that I had when we had that conversation. I don't know if you remember it, Rhea, several years ago. Yeah. And some of these concepts were also brought up. I guess one of the things I'd like to also drill down when we're talking about differences in the community, Barbara, you had mentioned, the importance of family. And we all know in the Hispanic families, family is paramount and extremely important. But I'd like to turn this to Jessica, because in the gay and lesbian and transgender community, many times people are disenfranchised from their families. They're then facing a critical issue in their life, facing cancer. They don't have that support mechanisms. Many times, they develop new families, so to speak. And I was wondering if you could talk about that and what your organization does cognizant of that fact.
So my organization specifically has not broached the topic. Again, because we work mostly with pharmaceutical companies and working their way down. What I can tell you from personal experience is that marriage equality has really helped a lot. So my aunt's wife, my aunt by marriage had cancer. And one of the few reasons that my aunt was able to be with her at her doctor's appointments, when she was in the hospital, to make decisions about end of life care, that made all the difference, legally. And, 20 years ago, that wouldn't have been the case. And so I'm very cognizant of the fact that having equality in terms of family, being able to have that chosen family and have them legally be able to make those kinds of decisions it has a huge impact on patients and in cancer care. So Charlie Kamen and Ash Alper did a study in 2019. It's a wonderful paper, and they went and they talked to cancer patients and survivors in the LGBTQIA plus Two-Spirit community and tried to, what were the biggest issues in their treatment. And there was a lesbian woman who said, I couldn't have my partner with me because it was a religious hospital. And I was worried I wouldn't get the right care if they knew I was a lesbian. And so, I mean, that's, in a similar situation, if they are kept from their family, from their support groups, that's going to impact their health and their health outcomes. So I guess circuitously, my organization hasn't tackled that specifically, but I do believe that, things like site and sponsor education, which we are tackling, can have an impact when you have PIs, cancer oncologists, people who are specialized in this, having those cultural competencies to, at least in their clinic, be able to have those conversations and have that awareness and that cultural humility and training to be able to treat their patients holistically as a whole person.
Mm-hmm. Yeah, great. And also by having caregivers be of the community, so to speak, I think, and be recognized as such to the individuals, I think is extremely important also. That form of identity and bond, basically, too.
If I can jump in here for a second as well, I think just to sort of put a finer point on that, we hear a lot from the AYA community, especially those who don't have partners, many of whom are new to the healthcare system. Being in a hospital is a brand new experience. And so their parents are their main primary caregivers and oftentimes don't accept or recognize whether they've come out as gay or thinking about transitioning. And that really creates a challenge in the doctor's office. They don't want to use the pronouns that their child wants to use. They're having conversations about fertility that maybe the patient's not ready to have. And we've heard that this is also reiterated on the provider side, that, there's assumptions made about who your partner is and whether or not you want to have children and, what your fertility pathway looks like. And I think it kind of circles back to what we were talking about in the very beginning when we kicked off this conversation on that peer-to-peer support and how critical that is, certainly within the AYA community, and I'm sure in all of yours as well, that there is that sort of new family that you create with other folks, with other young people who are going through what you're going through, who really get it, who know what it's like to walk into a provider's office and have to go through your pronouns again, and how re-traumatizing it is to have to come out to every new doctor that you see. So I think, just sort of thinking about the role of who that caregiver is and what that family looks like is really important in these conversations that we have with patients, because sometimes it's not the obvious person. Sometimes it's not the parent. And sometimes the providers aren't thinking about that. And one of the things that we're doing at Stupid Cancer is putting out some misconceptions videos, as we're calling them, in the next couple of weeks, where we're from the AYA's perspective, sharing what they would like providers to talk about, or how we can be more inclusive and understanding in the conversations that we have, and sort of get away from some of these assumptions that are just ingrained and built into these treatment conversations that we have.
If I could add one more point to that, asking people what it is that they need and what they want is so key. Making sure you have the right voices at the table. Often, decisions are made for communities by other communities without knowing what it is that they actually do need and actually do want. There are a lot of assumptions. Dr. Scout with the LGBTQ Cancer Network often says, make sure we're at the table, but not for dinner. Making sure that you can't treat people unless, again, you see them holistically and you're taking their wants and needs into consideration.
Mm-hmm.
Can I just throw something out here? I mean, I appreciate, because this is extraordinarily important conversation that you're having for us. So we appreciate that. I'm curious, though, it seems as if there's a consistent thread, and I'm wondering how each group gets past it. Specifically, Jessica, you're looking for data. You're looking for opportunities to bring more people into clinical trials who otherwise have probably been excluded. Duly noted. How do you get those individuals to trust and to appreciate that their role is significant? What is the magic potion for getting people to participate on the individual level?
I don't know that there is one. And here's why. So the company that I work for does collect. We just started collecting sexual orientation, gender identity, and intersex status in all of our qualifying clinical trials in the United States. And the sites themselves have an option to collect the data because it's electronically on a site pad. And then the patients have the opportunity to answer the questions or not. We're finding about 50% of sites don't even turn on the questions. And of those, only about 50% of patients are actually answering them. And, and it's understandable. The political climate right now, it can be a patient safety issue to publicly say, hi, yes, I am a transgender woman, or hi, yes, I am 18 and I am gender nonconforming, but I'm not out to whomever. In some states, parents might worry about having their children taken away if they come out as transgender. So yes, we want the data, but there's this huge asterisk, and we do have the understanding that it kind of goes both ways. We need to tell, doctors and institutions and pharmaceutical companies, like, yes, it's important to collect this information. And we need to make a safe space for them to be able to do that. And that's why our site and sponsor education, I think, is so important. I don't think that the onus is necessarily on community members to advocate for their own inclusion. And so I'm trying to, it shouldn't be an uphill battle for an individual person to be on a trial. As part of the community, I can work to help other people. But once you're in that position, it shouldn't be up to a transgender person to make sure that their clinic is safe. What it can be is on a larger, those of us who have taken on the challenge of making sure that it's a safe place and using their voice and their position and the tables that I get to be invited to make that safe space for them and recognize, like, there are a lot of moving pieces to this. I would love it if our clinical trials were totally inclusive and everyone disclosed. My goal is to not have a job someday because, we've solved this problem of inclusion. But there are just so many facets to it, and really needing to understand that it's not just medical, and it's also not just data, and it's also not just where you live. It's all of them together. It's very intersectional, and you can't, I don't think that there's a magic solution, because each individual patient is going to have their own individual concerns as to why or why not they feel like they should participate in clinical research. Sorry.
No, go ahead. I'm going to comment after you finish.
I was going to say the best that we can do, and what I hope is what I can contribute to this space, is making them as welcome and safe as possible should they choose that path.
Because I think education is, we learn at SWOG Cancer Network, one of the patient advocates is LGBTQ, others. And I have learned a lot from him, and him sitting there and giving us, in your face, different details. It's like when I started on SWOG, my first question was, how many clinical trials done by SWOG had impacted Latinos? And by 7 years ago, they were not collecting that. Now they have dashboards and all the things, because now DEI in the last 2 or 3 years is kind of the flavor of the moment, right? But as many people as we empower to open their mouth and say, somebody's going to listen, not today, not tomorrow, but maybe the day after tomorrow, right? And, watching you and watching Joel, that is the guy that works with, I collaborate with in SWOG, it's that. And when I trained this group of Latinas, I gave by example all these other things that I have then done, and is kind of the voice of one. But it had made a difference. So if we have the voice of 2, and then the voice of 5, and then the voice of 10. So, seeing you really could give people empowerment and understand that, you're paving the way, but they also can have a say if they have the opportunity sitting at a table, at a party or whatever. We just have to empower people to talk, like Ria was recommending. We all have to. And at the end, it takes time, but hopefully we're all here because we want a better world, right?
Great points, Barbara. And if I could say that I'm advocating for on behalf of the patient advocate, we need more of them because it's not just a matter of educating patients and getting the information out there. People want someone who talks to them that looks like them, that can identify as with them. You know my cultural background, how I fit, like maybe as the matriarch of the family, how to approach and talk to me. And when we can have patient advocates who understand that role, who then go out, and I'm going to say, for me, it was not just walking the walk, but talking the talk, but walking the walk and using your own lived example. You're going to get maybe more people who want to speak up and be in that place. And the reason I say that is because, for years I was advocating that we should, that people of color should be more involved in clinical trials and that, better treatment options would be great for them. And yet I had never been in a clinical trial myself. And so I made that a purposeful goal for me to make sure that I became involved in one as a 3-time cancer survivor. And so I'm proud to share my little hospital tag that identifies that I'm involved in a clinical trial so that I understand from a patient's perspective, those feelings that they have, like, should I join? Or for me, I was never even asked by my oncologist, do you want to participate in a clinical trial? It took me becoming a seasoned patient advocate to even understand that role and reach out to a PI myself, asking about being able to participate. But I participate, if I can say quickly, because I want to make a difference. I want people of color to understand that there are other treatment options out there that can extend our lives. And that, frankly, for me, it's really personal because my family has a 50% chance of being Lynch syndrome positive. But if they could take a vaccine that eliminates the possibility of them having cancer, then I've left my mark. I've done what I could do. So while all of us here are on various organizations, it's so imperative that we're not just talking the talk, but walking it as well.
Barbara, Winora, should every patient be a patient advocate?
Well, that's the funny thing. Not every patient wants to be a patient advocate. But for those who maybe just want to share their story or, have someone speak on their behalf, we just need more voices like that. And believe it or not, I see the impact that it has on our research, for our scientists, those who have never been outside of a lab, who've had an opportunity to even talk to a patient or a patient advocate. It's giving them aha moments and light bulbs and a different look at this.
We have many.
They should advocate for themselves. I just wanted to add, they don't all have to be advocates, but they should all learn how to advocate for themselves. That's the difference.
I actually do want to just add to some of what was just said. Thank you, Winora, for bringing up the importance of racial and ethnic concordance. I think, yes, when possible, we've seen in the research, we do it in our own work, as I mentioned with the docuseries and our peer program. But when we can't, and I get this question from providers, I get it from industry, what happens when you just live in an area that's not super diverse? What happens if you have people who are well-meaning, who want to engage members of other communities, but you can't get that racial and ethnic concordance, or you don't have a practitioner who is from the LGBTQ+ community, et cetera? I think here the onus really is on those who are involved not only with policy, but also with just developing the workforce to say, okay, great, let's talk about cultural humility. Let's talk about cultural competency. This is very briefly covered in the trailer, but it is covered more in depth in the film, right? Learn to look at the person who is in front of you as an individual. Stop thinking of groups and conceptualizing them as monoliths. Implicit biases in healthcare are still very, very common. Get some training on that, but don't just go through this, 3-hour online training so you can get a CME or so you can get credit for it. Actually embrace it and ensure that as you're developing your workforce, you're hiring people and you're promoting people who actually live it. And as Winora just said, not only talk the talk, but walk the walk. I also just wanted to very briefly touch not only on what you said about the onus, Jessica, being on individuals or on patients, but again, also on practitioners as well for clinical trial and industry. This is a difficult problem, and it's going to take multiple people and conversations to solve. And we can't just be looking at those who are not, or who historically have not participated as often in clinical trials for solutions. We have to be looking from, I think, a systems lens and an institutional perspective as well to figure out where we went wrong and what we can change so that individuals can feel more comfortable, can be able to make informed decisions. We're living in an age of misinformation and disinformation. It is so easy, as we've seen with COVID-19, to access myth and disinformation. We have to be willing to really have these important conversations to get the right information out there and think about different avenues to get that information out there as well.
One of the things that we're very interested in is having greater patient involvement in our regulatory work. And obviously, Ria can address some of those issues since we have found it in the OCE project community, really to bring the community into the agency, so to speak. But, you know, the FDA has such of a profound effect on what patients will ultimately get as far as approved therapies. We really want to hear more of the patient voice in this. One of the things that I have been somewhat disappointed in is sometimes the lack of patients at our advisory committees, okay? Most of the patients that we see at the advisory committees are patients that have been brought in by the pharmaceutical industry, and let me tell you that they only give one viewpoint, and that viewpoint is highly favorable to the drug under consideration. I wonder why, okay? But we really need to have a diverse, and I've used that word both in terms of representation of ethnic and racial minorities, but also a diverse opinions regarding drugs, because not everybody gets the best results from a therapy. And we tend only to hear from patients that are carefully curated by the pharmaceutical industry only to give the most positive results. So I want to put that plug into the advocacy community to bring these voices to our advisory committees within the FDA. We need to hear from the general experience of patients, and not only those patients that are curated and carefully selected by industrial sponsors to give the most favorable aspects of a drug. So
I think sometimes it's that they don't get the information, right? Because
I know. I think
you
most
always have the usual suspect, because we don't, like when I go back to the Latinos, we don't have a network. Now I have 15. Right?
I think one of the things that we could do better is, you know, in our patient newsletter, even advertise when these ODAC meetings are going to be held to encourage patients to really participate in the open public hearing. The whole purpose of the open public hearing was to bring diverse viewpoints in regarding a drug. And again, I'm using that word in the dual context of racial and ethnic, gender minorities, but also diverse opinions on whether the drug works or not, and not simply have a curated small group of people where their expenses have been paid by the pharmaceutical industry. We always will have a virtual component where other voices can be heard if they cannot afford to travel to, Silver Spring, Maryland, that's for sure. But that's an area that we should work on.
Duly noted, Rick. I have homework after this conversation on cancer.
It just popped into my brain here.
Of course. Yes, that's always what happens. Yeah. I just want to note for the panel that we're winding down a little bit. And if we want to have time for everyone to have their last remarks or future focus, maybe we should start now. What do you think, Bindu?
Yeah, that sounds good. I think we've had a really interesting, conversation. I did have just one last question before we move on. A lot of the themes and, the education and awareness that we've been hearing is a lot of, done through digital and social media. And I'm just wondering, the panelists' thoughts on this, because, there are, even this could sort of, there are disparities in how people have access to this digital and social media, or are we living in an age where, now everybody can utilize these services? And just wanted to hear your thoughts on, other programs you have, for education and awareness that go beyond this, social and digital media, and wanted to hear your thoughts on that.
Absolutely. I think that, no, the digital divide very much still exists. Digital illiteracy concerns are shared among our patients and their loved ones. This is where our 189 brick and mortar locations come in, right? We do have these digital offerings, wonderful apps, resources and programs on our website, videos that I mentioned and that we shared earlier, but we also print a lot of this material out for patients and their loved ones. We have folks who are very much concerned with having one-on-one in-person conversations, who will meet, again, people where they are if they're not able to access transportation to get into a location. We do have hybrid offerings, but for people who maybe just aren't as comfortable with using even a computer or with telemedicine, we take the time to not only engage them around their concerns and kind of barriers they may have to access, but also to be creative and I think mindful of how people learn, the different ways that people learn, and the different types of media that might best engage them. So to answer your question, yes, it's great that we have all these digital offerings, but we have not forgotten about people who either might not be able to access them or just might not feel comfortable or who aren't as digitally literate yet.
And it's understanding the community. Like another fact is that 20% of the Latinos are dependent on their smartphone. They don't have computers home. And then if you have maybe 2 or 3 kids, they're using their phone for their looking in their internet for their assignment. So that is a challenge. And another thing is every culture is different, but use one platform more than others, right? For Latino, it's very much Facebook, and I can attest to that. And also a WhatsApp. We created a WhatsApp group for the Latino, and Sandy, who's from the state, was like, "Oh, these Latina talk a lot because of ding, ding, ding," right? And so it's understanding again how you can reach. Everybody is different, and even with older people, right? Not everybody has the facility, so it's having that conscience. And when we talk about approaching clinical trials and just doing everything digitally, it could be a bigger divide if we don't think it through.
I mean, it goes back to grassroots too, the old fashioned, like you said, handing out information, those in-person support groups. I know COVID did a number on us, but here at Force, we're going back to an in-person conference where people can network and see their friends and colleagues and see what's going on that's new in the space. So those are just small recommendations, but there's just a lot of work to do in this effort.
Yes.
Great, thank you. Ria, you can take it away.
Okay, well, maybe now we're down to the final thoughts. I know there's been a lot of thoughts percolating among this group, and I do want to commend you for your leadership in this conversation on cancer. It really is, I think, the appropriate thing to do for National Minority Awareness Month, Health Awareness Month, cancer prevention, cancer control. There's all kinds of labels on the month itself, which is not necessarily the most important thing. What's most important is the community engagement that you all represent. And that's something that we all can learn from, whether or not a person has decided based on watching this that they might want to be an advocate for someone other than themselves, or maybe they want to, get on the policy side and try to figure out, how do we make sure that there aren't as many limitations in regards to clinical trials, et cetera. I'm just going to hand it off in a round robin here, asking each of you maybe to go, 30, 40 seconds-ish. A minute is okay. But your final thoughts on what needs to take place going forward, because we do have some conversations repeatedly, and it feels like we're not necessarily moving forward at times, but what would be the one thing that you think a year from now might make a difference? Jessica, I'll start with you.
Thank you. I have had a lot of thoughts percolating, and, a year from now, I think that, there have been so many common threads throughout our conversations, and I really believe that increasing visibility and access and equity in one community impacts all communities. None of us are in a community, only one, right? So I truly believe that advocating for each other and working on pulling these threads across all of these different communities is to the benefit of everyone and to the benefit of cancer research and patients and science altogether. So 1 year from now, Hopefully, we've all achieved a lot of our goals, but I would also love to see a lot of collaboration and advocacy for each other and across these communities.
Thanks. Melissa?
I was really hoping I didn't get called first.
You didn't.
I was like, I want to have a great answer. A great question. Again, I think sometimes some of us are like, what are we doing tomorrow? But again, I think seeing that bigger picture and the impact that we want to have. And I think the work that we do at ACAF and, how we can see ourselves improving that needle in a year is to really educate and empower our relatives, our tribal leaders, our patients, health systems workers, to tribal leaders, to policymakers, to give them the tools to help educate and empower everyone to help our relatives get screened and to see that early detection is key. And that we can do that collectively, right? We don't have to recreate the wheel. Like you said, we've had a lot of the same talking points. I think the information's there. It's just, again, coming together as a collective to really know that we're there for each other and for each other's population.
Allison.
I'd like to borrow both of those answers. I think both Jessica and Melissa are spot on. It's really, we're all saying the same thing. It's time to just do it and support each other in doing it. And with that caveat that we're not putting too much on the patient. I know we talk, and we at Stupid Cancer do as well, talk a lot about self-advocacy and arming the patient with all the information. But, ultimately they're dealing with a cancer diagnosis. They've got a lot on their plates. So how can we as patient advocates and all of these empowered people in this Zoom room and the folks listening and folks at the FDA and at these institutions that are hosting these trials, how can we work together to make sure that the things that we talked about today are actually happening on the ground?
Barbara, I see you taking notes.
Yeah, no, and it's about working together. It's learning from each other because as Addison was saying, we all are gonna, I'm gonna have an AOA Latino, I'm gonna have a sexual gender minority Latino, I'm gonna have a Black Latino. So we interact with all of these communities. So understanding more their issues and their needs, we can bring it to the work that we do. So I appreciate being in this Zoom today, because every time I participate in something like this, I learn more than I can deliver. So collaboration and working together, I think, is the key. And thank you for the invitation.
Oh, thank you. And I have to say, Winora and Audrey, I know that you've worked together on various other panels. So the deck was a little bit stacked, but that was just so that we could all be comfortable in this room. So Winora, your turn.
Well, I'm going to say I love everyone's answers as well. So I'm going to go a little bit different route. I'm going to mention a quote that Maya Angelou once said, and she said that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. So for me, it's make people feel respected about their choices in healthcare and just support them, period.
Thank you. I feel good just hearing that. Audrey?
Anxiously setting my stopwatch so I don't go over time. For me, it's very specific. We're currently standing up a project called IDEAL. That stands for Increasing Diversity and Equity Through Advocacy Leadership. We'll be training IDEAL ambassadors from several different socio-demographic communities on grassroots policy advocacy at both the state and federal, but also local levels to, as I mentioned earlier, impact not only institutional change, but also really policies being made that are about our cancer patients and loved ones anyway, but allowing them to have a voice to amplify their experiences so that these policymakers not only can learn more from them, but have their decisions and their votes impacted by those experiences. I'm really excited about the IDEAL. Stay tuned for more information. 46 seconds. Thanks.
Oh, look at you. And that sounds ideal, by the way. I just want you to know. Again, special kudos to Audrey for a conversation we had many months ago in which we really wanted to bring advocates from all diverse areas into a conversation on cancer where you really led and demonstrated the leadership that you have in various communities. And we know that's not the end. It's just the beginning. But Bindu, I want to hand over to you and then Rick, and then we'll wrap it up.
Thanks, Ria. again, sincere thanks to everybody. It was a really great conversation. And as Ria mentioned, this conversation was really meant to be led by you all. And every time I hear an episode of Conversations on Cancer, I'm extremely humbled when I hear from the patient advocates. The work that you've done to increase awareness and education on several aspects of cancer and having patients, participate in clinical trials as well as, survivorship is just tremendous. And I'm extremely happy to be part of this conversation today. And so thank you all for joining us today.
Boy, 90 minutes flew by quickly here. I just want to emphasize, we want to hear from you. We want to keep this dialogue going. As a government agency, we represent you. We need to hear your voices, what your opinions are regarding what we do. We hear from many people, but sometimes we don't hear from the most important people, and that is the patients that are receiving our drugs and the treatments that we approve. So we really need to hear from you, and that's part of why we formed Project Community. Take it away, Ria.
Thank you, Rick Pazder, for your guidance and leadership. Isn't it cool to be here? And by the way, Conversations on Cancer is yet another example of Rick's guidance and leadership. He decided that we needed to have a series like this where we talked about all kinds of issues, often social. So kudos to you. I do want to just very quickly say to everyone that our next Conversation on Cancer is specific to our 4th annual National Black Family Cancer Awareness Week initiative. We have a special hashtag for the social media aspect, which is hashtag BlackFamCan. Hashtag BlackFamCan. The Conversation on Cancer will take place on June 13th, beginning at 2:30 Eastern. The registration is now open. It's part of our attempt to continuously be inclusive and diverse and reach all of the groups that need to be reached. And by the way, you don't have to be Black. Please don't be limited by that. This is open to anyone who cares about people dealing with cancer. It's just this specific minority group is where we started. We're also, and I mentioned this to Barbara in February, we are moving forward in September to do our first National Hispanic Family Cancer Awareness Week, and we're definitely working on making sure that we're reducing all language barriers. Easier said than done for someone who doesn't speak Spanish. Just want to thank you all for your participation today and your guidance, your leadership. Thank you for your advocacy, truly, during this Minority Cancer Awareness Month. And we really hope that we will have greater engagement with you going forward. That's our plan. And Project Community and all of OCE and the FDA, thank you very much for participating today. Thanks.